Um, Good afternoon, colleagues, and welcome to our webinar. It's 2:00 exactly, and it is my pleasure to introduce our esteemed speaker, Dr. William Mapham, who will be leading today's webinar on transforming healthcare access with Vula Mobile. And just a short, brief introduction of Dr. Mapham. He holds a fellowship from Columbia University and is part of the MIT SOLVE program, and he has completed the Stanford SEED program, and he has published extensively on social entrepreneurship and public-private healthcare. And today he will be talking about his innovation that he launched a Vula Mobile in 2014, which connects health workers via an app. And Vula Mobile supports a growing network of over 40,000 health workers. And we can actually call it the glue that holds the healthcare system together and the oil that makes it all work efficiently. With no further ado, I'm going to hand over to Dr. Mapham to take us through his presentation. Thank you.
Thank you so much. And it's really special to be part of this webinar. And thanks to the GTAC team for inviting me to the event last year. And really excited to share with you today some of Vula's journey, my personal journey, and what we can do to make a difference together. So let me just share my screen. We did do a test. So Dubuntu, can you see my screen?
Yes, I can see it.
Perfect. So I thought I'd go back in time a little bit to see, why does Vula actually exist? Like, why would a medical doctor make an app? And so it kind of goes back to a rural road. I'm from the Eastern Cape. I'm not sure how many people online are from the Eastern Cape, but obviously it's my favorite province. And this was the road to Madhwaleni Hospital. It's where I worked. I was a very enthusiastic junior doctor. I actually volunteered for community service, and 3 of us ran the hospital there for a couple of years. There were 3 of us running the hospital with about 250,000 people in our drainage area. Just to give you a sense of what rural means, this was the main road to the hospital. It was an hour-and-a-half drive to get petrol, just to give you kind of a sense of what rural means, or meant at that stage. And you can see some of the roads were terrible. So when we went to do outreach to clinics, this was the kind of thing that we were expected to do. It was quite fun driving, but there were very strict speed limits in the area, and you often got stuck in traffic. So it's a bit like Johannesburg, I guess, but in a different manner. This is Nomzingisi and I. We were doing vision screening in the rural areas. So we'd actually have a paper vision test. We'd stick it onto the JoJo tanks. We'd have like a mask. Sorry, I've got some. Thanks for that. And then, so this is the kind of thing that we would do. Again, very enthusiastic, trying to do our best, but obviously limited by what we had available. And there are some cases where, I know we're talking about data and apps and digital, but there are some cases where digital doesn't make a difference. And so this particular gentleman, Nomzingisi, and I met. He had actually gone completely blind. If you look very carefully on the right-hand picture, you'll see that the pupil, which is normally black, is white. That means it's a cataract. It means the person can really only see if you shine a light at a piece of paper and you can look at the light on the other side. That's how blind he was. And fortunately, the surgery for this is cataract surgery. It's relatively simple to do, but he didn't want to go. We gave him all the information in the world, and he said, "There's no way is he touching my eye." No one in this clinic, no one in the village had ever gone for cataract surgery before, and he was very scared of losing what he had. Eventually, we managed to persuade him that he had 2 blind eyes, and would he please trust us to operate on one, and then he can make a choice what to do with the second one. And he did actually go for cataract surgery. He managed to operate him and bring him back. And then seeing him walking around the village and being able to see for the first time in many years, the next time we had an eye clinic, we had a long queue of patients waiting to see us. It wasn't all easy. This is a letter that I wrote myself in 2004. Patient had come with an eye condition to our hospital. In the rural hospital, you have to do everything you can do your best for all the cases that come in the door, but there are limits. So we didn't know much about eye care. And so I wrote this letter and I said, please go to Mthatha. It's our nearest eye clinic. It was only 3 hours away. And I hope that he would then get the help that he needed. The tragic part of the story is when I went back to volunteer 7 years later, he was so excited. He came to me with the same letter I'd written 7 years before, which is how I got this photograph. Sadly, he had gone blind in that eye. And looking at it as a specialist, realized it was actually a very simple condition. Had just gone untreated for a long time. And worst of all, we even had the medication he needed the first time I'd seen him. I just didn't know that as a junior doctor. And if you speak to any doctor and ask them about the ghosts of patients past, I'm sure they'll tell you a few stories of ones that already haunt them and hopefully help them or help me become a better doctor in the future. However, it was only when I was specializing that I realized the problem wasn't just in the rural areas. This is me seeing patients, I'm teaching students, more patients are waiting, and this phone in the corner just rings with people like me in the past, rural healthcare workers or GPs, trying to get advice or an appointment, and it's impossible to do everything at once. I just want to show you some of the transport problems that we face in rural areas as well. The distance from Nababib Clinic to Kimberley, which is your nearest eye clinic in the Northern Cape, it's over a 7-hour drive. So it's almost faster to fly from Joburg to Europe than it is to get eye care in the Northern Cape. And back when I was in the Eastern Cape in 2004, we did a mapping and we mapped all the different health facilities in the Eastern Cape. And this will become relevant later. So please remember this slide. But you'll see the left-hand half of the Eastern Cape has relatively few health facilities, and the right-hand half is packed with health facilities. And the main reason for that is that the left-hand side has roads and the other doesn't. And the health department had made a commitment to people that you would have a health facility within an hour of you. And so in rural areas, this meant that you had to build many, many, many health facilities. Whereas in the other half, you could have a health facility every town. So that's the difference that roads can make for healthcare. So I also like collecting bugs or taking photographs of bugs, and a bit like software bugs, realized there were a lot of bugs in the system that we needed to fix. Working in a rural hospital isn't always easy. To be honest, I got burnt out. I got frustrated about the speed that we couldn't change things faster. But this is a quote that when you encounter difficulties and contradictions, don't try to break them, but bend them with gentleness and time. And I think I kind of, in a sense, broke myself trying to make changes too fast. And so what happened next was that I kind of wandered around. I wasn't really sure what to do with my life. So I worked for the Rural Doctors Association, the Rural Health Advocacy Project. Noise.
Hello, can I ask you that you mute your mic, please?
There we go. Thank you. Also worked for Africa Health Placements. They're the recruiting doctors to go into rural hospitals. Not sure who's that, but I also worked for the South African National AIDS Council. So you can see I was chopping and changing jobs. I really was a bit lost. My favorite job was at Soul City. I don't know if everyone else remembers Soul City, but it was a mass media TV show and radio show and with print media. And we had the primetime TV show on SABC1, and health issues were built into the storylines. Also worked in Hillbrow, the Hillbrow Health Precinct, Wits RHI. So you can see I really was wandering around. I wasn't really quite sure what to do next. I eventually ended up at Stanford doing a course on persuasive technology. So this was how to use technology to change behaviors. And we had the first ever mobile health conference. So mobile technology and healthcare. And I think there were 30 people in the room. I think this is 2006. So it really wasn't much of a thing back then. But nowadays, if you go to a mobile tech conference, mobile health conference, you'll be a lot more people. One thing led to another, and I ended up getting a job in Washington with a company called Voxiva, which was the power of the internet and the reach of the phone. I could program USSD, which is basically please call me's at that stage. And essentially, we were making apps that helped American people get skinnier and smoke less. But that was obviously very far from my dreams. So one of the things I did while I was doing that work, I managed to publish a paper on mobile phones, changing healthcare one SMS at a time. Please bear in mind that SMSing was really cool back then. We had no WhatsApp or other things like that back then. Then I'm going to tell you a story, one thing you shouldn't do. And what you shouldn't do is go rock climbing. I had a bad fall. I really thought that I was going to be the end of everything, but it really woke me up. And rather than like doing all these random jobs, to go back to do the things I really, really felt passionate about. And that was going back to rural healthcare. So went back to the rural areas, this time to Swaziland, to work at the Vula Amehlo Eye Clinic, learning how to do cataract surgery, which would benefited patients in the Eastern Cape later. And again, we were doing vision testing with a paper card. And so that's actually where Vula gets its name from. It was while I was there that I realized that we should not really be testing people with paper. There must be a better way to do it. And so this is the team of healthcare workers that were there. I was trained by an ophthalmic nurse and a doctor who had a diploma in ophthalmology. And it was the only eye clinic in the country. It was paperless, incredibly efficient. So at last I saw the way that technology could actually improve healthcare services. So that's where Vula began. And so the first one we made, you can see on the left there, it's a very ugly thing. I made it on PowerPoint. The first version was called Operation Site. Didn't really work very well, but it was the start. The next one we built was a little bit better. Again, this is me building on my own. There was a system at that time called Productivity on Paper. It's now called Marvel UX. And if you want to try building your own app, it's quite a nice, easy interface for you to have a go. But that wasn't really going to go very far. And so we applied for funding wherever we could find it. And we were very fortunate to win the SAB Foundation's prize in 2013. And that enabled me to launch Vula on the app stores in 2014. As a doctor, I thought that making apps was going to be super easy, super cheap. Anyone can do it. So I thought I could build the whole thing for 60,000 Rand at the time. And I quickly learned that technology is not that cheap. The first version of Vula cost about 400,000 Rand. And then who's going to pay for the ongoing costs? So it wasn't as simple as just building it. Software's software for a reason. Every time Apple has an update or Android gets updated or a new Huawei phone comes out, you almost have to keep changing in order to stay present. So I was so chuffed to eventually have Vula on the app stores. We built our own chat messaging system, which was secure as opposed to WhatsApp. Initially, when it was eyes only, you would send an I message, an EYE message, which we thought was very funny and cool. But you could do a vision test on your phone now. And so it really started to take off, or we thought it was taking off. But once I built it, I realized that was just the beginning, because now they were incurring costs, and the more people that used it, the more it cost to run Vula. And I didn't really have a business model at that time. I was still working as a doctor. But what I realized is if you filled in forms, which is one thing that doctors are very good at, sometimes money comes back. So I filled in about 60 or 70 fundraising applications every year, and I had to win one per year. So very fortunately, we won one per year for about 6 or 7 years in a row, and that enabled me rather to keep Vula going. So it was very stressful because people were using it, and I didn't have a permanent way of keeping it operational. And so we started, and I was so excited. So that in 2014, We just got going in 2018. It was 46,000 patients in the year, and I thought this was really, really exciting. But now it's really becoming a thing on its own. And so in 2018, I actually quit practicing full-time as a medical doctor and decided to work on Vula full-time to see if I could max out the impact we could have. So as Nwunti said, the Department of Health have a quote, and they call Vula the glue that holds the health system together and the oil that helps it work efficiently. And we constantly work with healthcare workers to improve the system and make sure it's relevant and helps them. So we moved beyond eye care in 2016. One of the first specialties was burns, dermatology, and orthopedics were the first new ones. And now Vula is actually available in 75 different specialties. I didn't know there were so many specialties when we first started, but it's really exciting to see how other people are taking it up. So eventually we had our 100,000th patient, and we were so excited. We had a little cream donut celebration. We then had our 500,000, and the Vula logo is African beads being drawn together, like the connection between different things. And then most recently, we had our 2 millionth Vula, just the end of last year, which is so exciting. And that you can see the community of healthcare workers all celebrating with us. So in terms of Vula today, we are software that connects health workers, and our mission is to get patients to the right healthcare. It's one app. It can be used offline. It uses about a quarter of the data of WhatsApp. There's also a web platform if you've got access to the internet. And as you just said, we've got over 40,000 health workers on Vula currently. 2.1 million patients have benefited to date, which is about 1 in every 30 South Africans. There have been 12 publications on its impact done by independent universities. And one of the key things is that it improves the outcomes for patients, and it also reduces the costs for patients, health workers, and for the health system. And if you look at that 30%, you'll see that becoming relevant later as well. So essentially what was happening before, if you can remember that old letter that I wrote myself back in 2004, that's how referrals are done in some places still today. And mostly in the past, that was exactly how they were done. But as Vula develops and as people use it, suddenly everything is becoming digitized. And the world needs diverse data sets from developing countries. Otherwise, we will not be involved in the development of AI technologies and other health technologies that we need. So we really have to make sure that more of our health data becomes digitally available. I'll start to show you a couple of examples. So we built Vula for one reason, to connect a primary healthcare worker with a specialist to make sure that the right thing happens. But what we saw is that people started to adapt Vula. They put a burns calculator in that could be used for dermatology cases. They built the vision test into Vula. And again, like 75 different specialties now. So it's almost 1 + 1 = 75. And one of the key things that we found out was the healthcare workers' stress levels went down when they used Vula. So rather than hanging on a phone, trying to contact a specialist or contact a registrar, suddenly they are actually able to feel better and actually stress a whole lot less. This is one of the examples of the vision test being used. This vision test is currently being done in Vredendal Hospital. And sorry, once we built Vula for the one-to-one. Sorry, give me a second. But what we noticed over time was that as healthcare workers used it, every time they made a referral, they learned something. So Vredendal Hospital is a long way from Tygerberg, where I was working at the time. It was a 3-hour drive. And the nurse was making referrals and learning every time. And then all of a sudden, she stopped. And although we hadn't met her at the time, we panicked a bit. We thought maybe something had happened to her. But she said, no, she's fine, but she knows what to do now. She then also used the data that had been collected through Vula to motivate to the Department of Health why there should be a special clinic in Vredendal, It was now opened with funding from the Japanese government. And now once a month, a surgeon goes to operate for her, goes to operate for her. So the complete reverse of what happened to me as a junior doctor in the Eastern Cape. Here's another, it can't be a medical presentation if I didn't show you some gross photographs. But essentially, the story here is that this is a very simple piece of tubing. It's available in virtually every single hospital and clinic. It's called a butterfly needle. And if a patient has had a chemical injury to the eye and isn't treated almost immediately or as soon as possible, that person can go permanently blind in that eye. So we had a case that was referred to me from Khayelitsha Hospital, and the patient had had a chemical injury, and I basically sent these pictures through, and the doctor did exactly the right thing. I said, please send the patient to me just so I can check. The patient came in and was absolutely perfectly done. Typically, if a patient had come in without this, it would be 3 or 4 months of rehabilitation, and we might get the vision back. So it's a simple procedure, explained over Vula. The right thing was done for that patient. About 3 months later, a child was referred to Tygerberg, to one of my colleagues. And it was a child who had a chemical injury as well. And the doctor had already done this procedure and had already washed out the child's eyes. And so my colleague said, where on earth did you learn how to do this? And the doctor said, well, whenever they learn something on Vula, they share it in the clinic so that everyone gets a chance to learn from the cases. So it's amazing to see that we built it for one thing, but it's being used in different ways. Another thing that you can see is the health administrators and the heads of departments and the specialists can now see what healthcare workers are talking about, the questions that they ask each other, and can react accordingly. So this is a bit of a tongue-in-cheek case, but essentially the medical officer was brand new, was very junior, a bit like how I was asked to give enoxaparin to the patient, but didn't think it was in stock. And the specialist said, that's impossible. This medication is normally called Clexane, and you should have it in stock. And then the doctor wrote back and said, oh, yes, we do have Clexane. And it's something I would have said, perhaps, I'm sorry, I'm feeling a little bit stupid. So basically, now doctors are picking up the cases that can be used for teaching as well as just for actual clinical work. People are adding things onto Vula now. This is a 3D printed device. So if you have a 3D printer, we can send you the file and you can take a picture of the retina. This is the retina of my eye. The retina, in case you don't know, is the back part of the eye that has all the nerves that sense light so you can see. It's actually a form of your brain that's kind of outpouched towards your eye. So essentially, this is the only part of your brain that you can see without opening your skull. And so I did send this to my father to prove that I had a brain, although he was a bit doubtful. But essentially, you can see how people are adding things onto Vula to do more things, and it's really exciting to see how they're using Vula. So we talk about millions of patients, and 2.1 sounds like a lot. How on earth do you even imagine that? But I'm going to try and show you a video now to show you what getting specialist care means for one person. So we did an outreach to Daar. Daar is pretty much in the middle of South Africa if you throw a dart at the bullseye. We went there for a weekend. We operated on a whole group of people who were blind there. And in the morning, we took a video to prove to our wives that we were actually doing some work. And we just happened to catch this reaction from one of the patients.
Can you see my tummy? Okay, wonderful. It's okay. It's okay. It's okay. It's okay. Okay. Daar's sy. Nou kan jy jouself lei, né? Okay.
Yeah, so if you haven't pictured what getting specialist care in rural areas means, maybe that is a way for you to help imagine it. A patient is now helped on Vula every 40 seconds, and 30% of those patients no longer need to travel to tertiary hospitals because the specialist can give advice via Vula to the primary healthcare worker, and the patient is managed on site at their local area. So I'm going to show you a couple of things now that I find interesting, where data does make a difference. And I'm going to show you a couple of things that I really hate. So one of my pet hates is when someone says, this is a busy slide, but as you can see from the far left-hand corner, there's something interesting there. So if you think about this picture, like, it's absolutely meaningless. You can't even read the writing. Who knows what this is about? And I'm showing this as a very good example of a very bad slide. And there's a book called Where's Waldo or Where's Wally? And essentially what I find some people do is they're a bit lazy. They just put all their data on the slide and they say, look at this particular corner, and so suddenly you should be able to understand what's going on. So please, my one encouragement to you is never ever say this is a busy slide. Please put on the relevant point and leave it at that. And the reason for that is I want to show you how one data scientist changed the entire world with one picture. So this data scientist was Florence Nightingale. She's known as a nurse, and she's got the sort of the, I think people just said the lady of the lamp, but actually she was a hardcore statistician. She worked in politics, and she was determined to see how money was spent differently in healthcare. So what she did is actually invented the pie chart. The first person to ever use that type of graphic to explain health information. And not just a pie chart, what she did was she broke it up. So she took every month of the year and she showed that sort of quadrant for July, August, September, October going around. This is during the Crimean War. So it's in Ukraine, exactly where Russia and Ukraine are fighting now. And what she showed was that the red ones are where people are dying in battles because of the injuries they had, before they got to the hospital. The blue was patients who were dying in hospital from sepsis. They were getting infections and they were dying in hospital. Using this graph, she managed to convince the British government to invest in creating better hospitals. The word hospital comes from a similar word for hotel. So suddenly people got better care. And look what happened a year later when she managed to get all the budget she needed. She reduced the number of deaths from soldiers dramatically. And that's really how she changed our lives, because we now run hospitals with better care. And she really changed the whole world with one picture. So please, if you are going to show data, think of Florence Nightingale and see if you can change the way the world works the way she did. So there's a cool song by Huma Sikela called I Want to Be There. And I'm going to show you how we are trying to do what Florence Nightingale did in the past. So I've been talking about roads a lot. So if you look at all these colored lines, these are different routes that patients have had to travel that we've managed to plot using Vula. So you'll see it's quite a wide variety across the country. And Hugh said, I want to be there when the people start to turn it around, and I'll complete the quote just now. So I'm going to ask you all to imagine that you are the finance minister and that I am Florence Nightingale presenting to you to see how you should spend money in South Africa. We just had the budget speech, but we still have a lot of poverty in South Africa. This is a map, and thank you so much for GTAC for sharing all the resources with me. It's really helpful. And so if you look at the different colors, you can see where poverty is greatest in South Africa. And so I'm going to take you for one journey to one hospital on Vula. Vula is used in 2,146 different health facilities. We're going to show you one at Ngwelezana. So in Ngwelezana, these are all the different routes on the right that patients have to travel. And the darker the color, the poorer the patient. So often you'll see here in the top right-hand corner there, that brown line that comes down, those are the poorest patients having to travel the furthest to get healthcare. We took the data from 1 month, from January this year. The amount of travel required for the patients was 582,000 kilometers, which is the same as going around the world 14.5 times. The equivalent time was 8,600 hours, which is the equivalent of a year's travel time for patients. This is to one hospital. And if you look at the cost, so that was about $500,000. And we've actually worked out the carbon emissions for all this travel as well. So you can see that every single hospital has a carbon footprint. And maybe there's something we can do to decrease that, decrease the costs, decrease the travel time, and decrease the distances that people have to travel. So let's turn it around. We know that Vula decreases the number of people who have to travel by 30%. So what does that actually mean? It means that patients actually decrease the amount of time they travel by the equivalent of 4 times around the earth. So if you're the finance minister and you're trying to convince your committee, you can say that Vula's decreased the amount of travel time by the equivalent of going around the world 4 times just for Ngwelezana Hospital. It's also the equivalent of 100 days. So picture this with 4 globes and 100 days. That's what you'll save from Ngwelezana starts to, well, they're using Vula, that's how much they're saving. Again, the travel costs are decreased and even your carbon emissions are decreased. So we know that Vula makes a difference. These are some nice quotes from the hospital. This is just anecdotal to back up what we've seen on the data. So it's qualitative data rather than quantitative. And they've seen that Vula saves a lot in transport costs, reduce clinic numbers, and save the patients a long and wasted trip. And the other nice part of it is that the healthcare workers get the data analytics every month, and they know they can't motivate for something if they can't prove it. So Vula stats basically help them to improve their services and to plug the holes in the system. So that to carry on Hugh's quote, it's I want to be there when the people start to turn it around, when they triumph over poverty. And all of you and I can play a role in this. You know, the government can have policies and guidelines, but at the end of the day, we have to make sure this actually happens. So you have the budget if you're the finance minister, and we'd like to hear you later of what you would like to do. And would you like to support Vula further at Ngwelezana Hospital? And remember, that's one hospital out of 2,146. I thought I'd share some stories with you. It's a bit of a sideline to Vula because there's so much data. One was from the University of Pretoria. There they used Vula in a different way. The family medicine department used Vula to get cases sent to them from clinical associate students who were in different clinics around the area, and they would teach them remotely using Vula as the chat system. What they then did is they looked at the summary of that data, and they saw things like male students are more likely to see female patients. All students preferred to see patients their own age. Students tended to gravitate towards patients where they already knew they knew the right answer, things like internal medicine or general surgery. They avoided patients from oncology with cancer, ophthalmology, or dermatology, where they didn't know as much. And they used that then to actually correct and rejig the syllabus so they could actually answer those questions. The worst case of this was actually at Stellenbosch University when I was working there. And all the students gave exactly the wrong answer, and they all gave the same wrong answer. And we realized then that when we checked it, there was actually a mistake in the textbook. So we felt very sorry and apologetic for the previous generations, but at least that's being corrected now. The Global Fund, this study was done last year and become more relevant now with the decrease in funding from USAID. Essentially what they did was they wanted to see across the 75 different specialties using Vula, where were patients with HIV, TB, diabetes, and hypertension actually being seen for the first time? So maybe rather than building HIV clinics and TB clinics with USAID money, maybe there was a different way. And what they showed was that patients often present earlier to specialties like ophthalmology and dermatology because they can see something on their skin or they can't see and they're having difficulty with their vision. However, when they looked at all the data, they showed that one of the key specialties where the patients presented the earliest and should definitely be connected to HIV and TB services was endocrine surgery. So endocrine surgery is your thyroid, adrenals, pancreas, those types of organs. And lo and behold, who would have guessed that they should be getting funding and linking patients to HIV and TB services? So sometimes you don't know what you have until you actually look for data. The AI story is interesting and happy to take more questions about it. But if you think about it, the Google dermatology AI and the one that's been released in Europe now were trained on very little dark skin data, let alone black skin. The Dermacyst AI was trained on 3% dark skin and 1% black skin. And so basically it's not really relevant to us in our country. So we really need to pioneer the way and actually grow our networks and create solutions that work for us. My last couple of points, don't give, take away. So what I mean by this is that healthcare workers are really busy. Don't give them an extra tool to use. Don't give them data collection. Don't give them a new electronic medical record system that makes them spend more time on administration. Create technology or solutions that take things away. So for example, Vula took away the time they had to spend on landlines. It took away the need for them to write things out. They can print from Vula or for all their patient notes, then to rewrite things. Took away stress, took away time for the patients. And that's actually, I think, if you do have sort of a mantra for implementing tech in healthcare, just remember to don't give, take away. And I thought I'd take you for an example of that. This is the grain silos in Cape Town. They eventually became disused. It was a very big eyesore. It was quite near the waterfront. Huge building, made incredibly strong with like really thick concrete. And no one was quite sure what to do with it. So what they did was they deconstructed it. They took things away from the inside. So they hollowed out the middle of those silos. And they hollowed out some of the other big blocks. They've created this into an art museum and one of the fanciest hotels in Cape Town. So this is a really good example. If you come to Cape Town and you see this building, just remember to don't give, take away. Maybe that's one way to remember it. We're very excited. The Vula team has grown, and in 2019, we were the best health solution according to MTN. We beat Discovery into second place, which was a nice little milestone for us. The UNDP has voted Vula one of the top 4 innovations improving access to healthcare. And most recently, last year, we were launched on the African CDC's marketplace for health technology. So we're doing our best to grow, but Vula was definitely built from the ground up. It wasn't a big company that came in to sell software into the Department of Health. It was literally designed by the health workers themselves. So I'm just going to encourage you all to come and join me in the Eastern Cape one day and to score a goal for rural health. And I guess I've got one ask from you. I would love to get more contacts in the Treasury who want to improve healthcare with a cost-effective digital health solution. And I'm really looking forward to your questions.
Thank you, Dr. Mapham, for such an insightful and interesting presentation. And innovation that assists the underserved communities. It's really, really great what you're doing with the Vula app. And I'm going to open the floor for questions. And I already see there is Mamiki who's got her hand up. You can take the question. Hi, Mamiki.
Or you can put questions in the
On the chat.
Yeah.
Mamiki, you can come through. Okay, while Mamiki is trying to come through and she's muted, we can go through to Tabiso.
Yes, thank you. I have a question for the doctor. Have you partnered? Sorry, I'm Tabiso Tebe, I'm from the Jobs Fund, and we have a project in the healthcare sector which focuses on expanding healthcare services to rural areas through nurses. And I wanted to know, have you done anything with Unjani clinics?
Yeah, I'm glad you asked that. So we are actually in conversations with them now. There are several Unjani clinics making referrals into the public sector and getting advice from public sector specialists. But we're very keen to grow and make it more kind of a comprehensive service for them. Yeah. Also an amazing initiative. I mean, it's probably one of the best ones in South Africa.
Yes, yeah, okay, thank you. Yeah. All right. No, that's fine. So you're already in contact with them.
Yeah, and if you've got more contacts, let me know.
Okay, I'll send you an email. Thank you.
Thank you, Tabiso. Dr. Mapham, we also got Puleng, who's got her hand up.
Hi. I wanted to ask, in terms of support, can you get people to support to make it sure that it's well? Currently now, they are still reluctant to utilize the Vula app. So my first to ensure that it.
Hi, Puleng. It comes and goes. I didn't hear your question, sorry.
Hi, Puleng, you just dropped off. If you could just repeat your question, please.
Can you hear me now?
Yes, we can.
Hello?
Yes.
Yes, Puleng, we can hear you. Or you can write your question on the chat and then we can just relay to Dr. Mapham to answer.
Because I wanted to ask about, in terms of support, can we get support to ensure that it's well implemented? Because I'm working in one of the facilities where you find that people are still reluctant in utilizing the app.
Yeah, so Puleng, please reach out to me so that we can work with you. We do a lot of work on behavior change, and you do get some people adopt it very quickly. And then we do have some sort of techniques that we use to help people get started faster. And we have a lovely, what we call our delivery team that can help you.
Thank you, Dr. Mapham. Puleng, are you sorted? You get in touch with Dr. Mapham?
Yes, I will do so. Thank you.
All right, thank you. We've got Mbulelo. Mbulelo's got his hand up.
Yes, thanks very much. And good afternoon to Doc, the colleagues on the platform. Thanks very much for the insightful presentation. I'm also from Eastern Cape, so I'm familiar with the areas that you were highlighting. Doc, your app is reliant on using, a mobile sort of in terms of network. Now, how is this? I mean, looking at the rural areas, there's always limitation in terms of accessibility of the community to this network. How do you then think you will be able to overcome that that challenge, more especially in the rural areas?
Yeah, so
Thank
it's,
you.
yeah, I'm glad you asked, because it was, I mean, Vula had to work first in those environments. So what we did is that it can be used offline. So basically you can see your patients, like, to be honest, there will never be cell phone connection in some of those valleys. It's just highly unlikely anyway. So what you can do is you can go into the valley and you can see the patients. Then when you get to the top of the hill, then you can communicate with the specialists. I can send you this. I'll put a link in the chat so that you can see an example of the BBC filmed of Vula being used that way, where the patient was out of reception and we needed to walk to the top of the hill to connect. We also made sure that Vula uses less data than WhatsApp, so it'll be usable in areas where where perhaps you won't be able to use other apps. So it's not possible to solve all problems, but we doing our best to make it practical.
Thank you. Thank you, Mbulelo. I don't know whether you are covered. There's also a question on the chat, Dr. Mapham, from Annery.
Yeah, so that's a good question. We don't have a contract in the public sector, so we have to fundraise constantly to make sure Vula is available in the public sector. And so we do have contracts in other countries and with private hospitals. In the Western Cape, the last time we had a payment was in December 2021. So since then, we've had to cover all the costs. And I'm determined to make sure we continue to do that. So yeah, we're not going anywhere. Thanks for asking, Annery. I guess to kind of sort of feed on that just as an aside is that if you think about it, software is often seen as a cost. So if you're running a clinic and you wanted to pay for Vula, or your clinic is going to pay for Vula, someone is paying from some budget. But the cost savings are often seen by patients, and that's not something that the health department looks at. So if you think about it, Treasury is actually the key place to go to for us, because the cost savings are at a systemic level, not just within a health facility. So I just thought I'd throw that into the mix.
Thank you. Are there any other questions or comments for Dr. Mapham?
Hi. For me, it's a comment, Dr. William. Thank you so much for your presentation. So last year, so I'm doing an MBA program, and we were once tasked to choose a health tech company that we would develop a business model canvas for, and we went for Vula. And but somewhere along the way, we thought, wow, this is so brilliant. And when you are in the healthcare industry, we are often told it's an industry of service. So we tend to not really think about commercializing most of the solutions that we come up with. And particularly for Vula, we felt like the founding story behind it is just so we were looking at different ways of how to commercialize it, looking at different revenue streams, different, just to make money. When you think MBA, when you think business, you think a lot of money. So for me, I actually had a question on cost, but you answered it before I could even answer it, because I wanted to find out, where are your main costs in running the app, which in the entire running of the app, where are the main costs at? But more so, it was just a comment for me to say it's such a brilliant concept. I wish it would be like a national program. I wish it would be something that would be incorporated into our public healthcare system, particularly now as we move towards being self-reliant as a country, to stop relying on aid and just look within ourselves and look at the different innovations that we have within the country to sort of move our healthcare forward. So the cost, Dr. William, and just the overall comment. Thank you so much.
Yeah, thank you so much for asking. Yeah, I think I mentioned that as a doctor, I thought you could build this thing for 60,000 Rand and everything would be fine, you know. And we have tried. Please send me your business model because I'd be very intrigued to see it. And I can send you our original business model canvas from 2014, just so that you can compare. We didn't get everything right back then. We went through different phases of generating or trying to generate revenue. In the very early days, it literally was just me filling in forms, and as long as we won one fund per year, it would keep things going. 2018, the SAB Foundation gave us a consultant to try and help us commercialize, which was amazing. Big fan of what they do, and the consultant really helped me, but it was rough. So we actually sold our car to pay the rent because we just didn't have a commercial model. But by the end of that year, I said, if we don't have someone paying for Vula, then it's not possible to keep it running. And at the end of 2018, we got a contract with Sanofi, which is a French pharmaceutical company. We won the Africa Tech Prize in Paris, and the prize was the chance to have a contract with Sanofi. What we didn't know is that over the last 10 years, no one had actually managed to do that. But it was kind of a do or die thing for me. And we managed to get a contract with them for 3 years. And actually, we still have a contract with them in Zambia now. So we've shifted out of South Africa. We tried advertising for a while. It didn't really work because not that many companies want to advertise to the public sector. And so the most revenue we could get there was about 60,000 Rand per month, which again isn't enough to run a whole app across. To give you a sense, last year it was used on 1,559 different devices, from Huawei, Oppo, Android, Apple, Google phones. Like it's just so the variety is so big now that you almost just keep having to run to stay in the same spot. So the costs are real, but if you look at the cost savings from Vula, then if we find the right partner within Treasury, then it should become obvious that it's worth investing in. And you talked about the funding and becoming more reliant. So in 2007, I was actually in a room, and there were a whole bunch of organizations getting funded by USAID, and I describe it as like a honeypot. Like all these organizations were sort of hovering around this honeypot and basically doing whatever the funder wanted. So it was funder-driven healthcare. And I know we've got massive problems now with the sudden kind of stopping of it. But at the same time, I think there was funding then, they called it hairdressers for HIV, and a huge amount of money was going to go to hairdressers to talk about HIV with their patients, or not with their patients, with their clients. And I just realized that the funding was going in weird ways. And I think like you said, we need to be reliant on ourselves, which isn't easy, but something that we have to become now. And I think that was the time to don't give, take away. Let's take away as much of the kind of the pain as possible and make sure that we improve the services as much as possible at the same time. Not easy, but I think that's what we have to do. But yeah, please send me your business model. I'm very intrigued to see it. We now have a SaaS business model, so people can pay for using Vula, currently at individual departments, or in one case, a hospital level. So whether you're in public or private, you are able to do that. I'm not sure whose answer was next. Augustine or
yeah. Oh,
you just
sorry.
answered Augustine. Tabiso, you can come through. Sorry.
Same question. Oh yeah, cool.
I'm not sure if it's my question that was being answered, but but I haven't asked. Can I go ahead?
Okay.
Yes, please, Thabiso, go ahead.
Oh, okay.
Teresa, was the same one around Njani clinics, or was it another one?
I think another gentleman is waiting to ask the question before me. Sorry.
Okay.
Okay, I don't think he's coming along, but my question was around the health department. So some time ago, I had proposed to the previous MEC for Gauteng Health around going to a paperless system. And I heard you mention that your solution is basically paperless. Is it something that has been adopted in there? And would it be something that will reduce costs for our healthcare services if applied?
Yeah, so we from the current studies we know, and the studies are from where it's currently being used, show that there is the cost savings. It's very hard for a department to go completely paperless, because if a patient doesn't have something to show the security guard as they walk in, they won't be given access to the health facility. So people do that, and they overcome that in two ways with Vula. One, you can print out the referral and give it to the patient. And then in some cases, they give a patient an envelope with the doctor's name on the outside, and they just say via Vula, and the patients are able to come on using the envelope. So although we wish we go completely paperless, there's still a few challenges there. And it is just starting to take off in Gauteng. I think Tembisa is our busiest hospital currently on Vula. But very keen to roll out faster if you've got contacts at the ministry.
Okay, noted. Thank you.
Thanks, Terry. So, Dr. Mapham, there's also Lionel has got his hands up.
Thank you, ma'am. And I'm Lionel Kunene from Jobs Fund, so inspired by Thabiso. My question is, from here, where to? For Vula are there some exciting developments in the pipelines? What are the future plans?
Oh, it's a lovely question. So for the next 6 months, we are currently the blockers to our own speed. So our processes for onboarding new departments, it's okay, but it's not fast enough. And so for the next 6 months, we're basically optimizing to make sure that the speed at which we're currently doing is going to be fast-tracked. The other exciting one we're doing is we aren't going to make our own AI. We have had several experiments building our own AIs, and it's not easy. It's expensive because your computing power costs a lot of money, and it's not always useful. So, for example, we had an AI that looked at a chest X-ray and it said whether the patient had TB, tuberculosis, or not, which is an important thing to know. But it gave a percentage, and if you tell a doctor the patient's got a 30% chance of TB or an 80% chance of TB, you don't give a patient 30% of a tablet or 80% of a tablet. Treatment is binary. And so although it was very clever, it was very cool, it wasn't actually clinically useful. It actually wasted doctors' time. And the analogy that I give for technology that wastes people's time is at the top of your screen where it says www. So www takes longer to say than World Wide Web. So the technology is actually slowing us down from what the thing actually is. That's kind of an analogy that I like to give. But so what we're doing in terms of AI is we're going to actually create a chat API. So like people are using Vula to chat to specialists, we will actually charge companies that want to have AIs that people can chat to on Vula. So the problem with all these apps is they have to go ahead and build their own database and community of healthcare workers, whereas we've got the community and we can partner with companies that we think will be useful. And so that's an exciting thing on our that'll happen later this year. And then the other one that we realized, all the research on AI that we've done shows the best thing you can do is to make your doctor's life easier. So to go back to that thing saying, don't give, take away. So ambient AI we see as kind of something that we're going to prioritize, which means that the doctor and the patient can talk. Vula's open on the phone, and it classifies all the information they've talked about, kind of like your meeting AI notes in the Teams thing here. So the doctors don't have to write anything down. So now you've taken away all that admin from the doctor, and the patient's having a better experience because the doctor or the nurse is actually talking to them. So I think those are some of the exciting things on the horizon in South Africa. And then outside of South Africa, our fastest growing country, we're growing in Lesotho, but also in Zambia. And I'm really excited to see how we grow there. We have had pilots in other countries, but the dream really would be for anyone in Africa to have the same standard of healthcare that we can possibly, the best that we can possibly provide given the resources available. And we're currently at 1 patient every 40 seconds. We want to be at 1 patient every second. And then we set ourselves a goal of having 1 million healthcare workers on Vula by 2032. So we have one long-term plan as well. Yeah, hopefully it gives you a sense of what we're up to.
Yes, thanks very much.
Thanks, Lionel. Augustine, I see you still have your hand up. Is it an old hand or?
It is current because I haven't asked any question. I'm not sure.
Okay.
Well, yes, I hope I've been heard. But yeah, thank you so much, Dr. William. I think, and congratulations on the excellent work with Vula app. I actually personally used it before at my previous hospital, and it was such a wonderful. It's really, and meeting you personally, well, virtually at least, contextualize it to what really I'm excited. Now, my part that you have partially answered, which you've spoken about your extension into Africa and to a lot of places. And currently we are setting up something similar to extend on the African continent, which we've been doing for a while. And I have kind of emailed you now briefly, but I will be honored if we could have a quick minute or two to get your wisdom. I think you will be one of the people that can give some guidance and insight to what it is, because you've traveled the road and we don't have to make all the mistakes that you have done, if you have done them already on our behalf. So thank you.
If there's anything I can do to stop people making mistakes I've made, I'm more than happy to do that. I don't know if you're familiar with the Bongani Mayosi Foundation. He was the head of medicine that sadly committed suicide. And then I'm kind of linked to his foundation now. And one of the principles there is lift as you rise. And so the principle there is that I make time every Tuesday afternoon to meet with people who need advice or want to avoid mistakes or anything like that. So if you send me a mail, then I can send you the options for whichever Tuesday is available. So I do my best to help like that.
Thank you so much. I have sent an email already, so I hope I can connect with you, and congratulations.
Thank you so much.
Thank you. Are there any further questions or comments? If not, I would like to thank Dr. Mapham and thank everyone for joining. And I just want to remind you to please visit our GTAC Knowledge Hub and website for past webinars, and this one will be uploaded in the coming week, and then the presentation as well will also be in the platforms. And if you could take a minute as well just to rate how was the session. I've put a link on the chat. And thank you so much, and have a very beautiful afternoon.
Thanks, everyone. I really appreciate your time.
Thank you for the session. What?
Thank you.
Thank you. Goodbye.
Thank you so
Okay,
much.
thank you.
All
Bye.
the best.
Bye.
Thank you. Have a great weekend further. Thank
Thank
you.
you.
Thank you.
Thanks, Awuchi.
Thank you, Dr. Mapham.
Bunch, I guess I have to rate myself.
You can rest yourself, but you did a brilliant presentation.
Yeah, only thing I'll say is invite me back.
We'll definitely will.
It was amazing to see how many people came. I mean, it's incredible.